And good morning. It is August 29th, 2023. I'm Dr. Duke Majan. Our patient here is having a cervical Duke laser disc repair shot. Cervical because it's the cervical spine or the neck, and Duke laser disc repair because he has two herniated degenerated discs, C5-6, C6-7. He's traveled from Australia to Florida. As a matter of fact, he's traveled from Melbourne to Melbourne. And he's been suffering with neck pain and back problems since, well, for years now. Shot? All right, so we're going to count first. Make sure we're at the right place. That's C2, 3, 4, 5, 6, 7. We're going to be fixing C5, 6, and 6, 7. We'll start at 6, 7, move up to 5, 6. Show us the endotracheal tube. That's the endotracheal tube. Show us the esophageal temperature probe. Our patient is intubated, asleep, under general anesthesia. All right, we're going to start with the discogram. I've already placed the needle, and what we expect to see is the dye leaking out through a tear in the back. Now this disc is pretty scarred. There is a little bit getting out there, but it's hard to see. And shot. Yep. I can't get any more out. There's so much scar tissue in this disc space from the degenerative disc disease. This patient has not just a herniation, but he has degenerative disc disease. His disc is degenerated over time. Now, some people get confused with our surgery. They think, how are you going to make that disc normal again? We're not. We don't do spine surgery to make discs look normal. If we did, we'd be out of business because we're never going to make a single disc look normal again. Once a disc is damaged, it's damaged permanently. Some people think their spine is supposed to look pretty when we're done, but we don't do cosmetic spine surgery, as Dr. Berndes pointed out one day. This is a 4mm incision. Once again, our patient has traveled from Australia to Florida for his neck and back. All right. We have a guide wire. We're going to remove now the needle. Shot. I'll move this Raytech out of the way. And shot. As I remove the needle from the disc space, I'll leave the guide wire. The guide wire will guide the next tool, which is called dilator. By the way, this surgery is FDA approved. We use only FDA approved equipment and supplies and medications. Everything we use is appropriately FDA approved. Shot? Yeah, so I'm making my way down, and I like to twist. Twist and shout. Shot. Now you can see the tip of the dilator, Jordan, on the lateral view is right at the front of the disc. Right there. Let's get an AP. I want to verify the tip is actually in the middle of the spine. Now his spine is in such bad shape, it's twisted and it's kinked off to the side because of such bad arthritis and pain he's had for so many years, which we've taken care of and we're going to continue to fix today. Perfect. You can see the tip of the dilator, show us, in the middle of C6-7. You can see the spinous process of 6, spinous process of 7, and this thing is dead center between the two, so it's as good placement as you can get. The whole surgery will be done through a 4mm incision. Unlike open surgery of the neck, invasive surgery, our surgery is minimally invasive. This is the most minimally invasive surgery that you can do. Shot? All right. At this stage, I'm going to advance this dilator to the back of the disc where the herniations are. Shot. Once we get back there, it's very hard, by the way, it's very collapsed. A little inline traction would be nice. Shot, that helped. I felt it. A little more. All right, and just a little bit more. Shot. Almost there. That's tough. There we go. Unfortunately, when people leave their herniated discs and don't treat them with the Duke laser disc repair you're watching now, those discs continue to collapse over time and degenerate. Of course, this patient had no idea that we even existed, which is the sad truth. Even though this technology has been around for 17 years here at Duke Spine, it's not available elsewhere. Because of that, patients don't know about it. After all, let's admit it, spine surgeons aren't going to recommend a treatment they don't know how to perform. Everybody ready?
He's watched hundreds of videos, he said.
Yeah, he's watched a lot of our videos. All right, let's get in there. I need a little distraction. Here we go. Shot. I felt it moving. Watch the tip, Luis. Shot. God, Berndes, you're an animal. I love it. That's all you, Berndes. I felt it. That's as far as I can go. All right, that's going to have to do. Great job, everyone. I may need a little help getting this out. If we can do one more inline traction.
Okay.
Beautiful. Great job, everyone. Oh, you're bent. You're just bent. Here. All right, I love it. I've never seen a cervical tube collapse. I have seen lumbar tubes collapse. Any questions from the audience?
No current questions.
Let's show our audience, why do herniated discs happen and why do they cause pain in the neck and down the arm? And welcome back. We are here removing herniation and bone spurs from the back of the C5-C7 disc at this point. A lot of herniation, a lot of bone spurs. Just to give you an idea of kind of how things stack up here, the laser fiber you're watching is the blue thing there at 12 o'clock. That is basically 0.5 millimeter wide, the glass part. If you look at the glass part itself, it's 0.5 millimeter. The blue part plus the glass part in the middle is about 1 millimeter. Oh, there's a herniation. See that thing pop out? Let's go all the way out. We got to float these little herniations out. Whoa, getting a little wet on my foot. That's good. That's good. All right. Now, his chest is big, so it's pushing against my equipment. Not that equipment down there, but my scope. All right, any questions from the audience about this?
No current questions.
So I get a lot of questions about bone spurs. People say, hey, Can you get rid of all the bone spurs? The answer is no. We don't want to get rid of all the bone spurs. We only want to get rid of bone spurs that are causing problems. Okay? If you try to get, first of all, there's no doctor on earth that can get rid of all the bone spurs. It's impossible. There are going to be bone spurs that are unreachable. But the good news is bone spurs generally are not the problem. The problem is herniated disc and annular tear. I have rarely found bone spurs that need to be removed. Yes, lots of people get bone spurs. We have bone spurs all throughout our body as we get older. But we don't treat them unless they're causing problems. Unfortunately, many patients believe bone spurs cause problems even though they don't, because they're misled to believe that. So that's a falsity. What do you call falsity, Dr. Berndes? Huh? Misinformation? Misnomer's a little different, but I'll take it if you say so. Misrepresentation? Really, the problem is not bone spurs. The problem, folks, is this right here. It's a herniated disc. See it? We're hitting it. Misinformation. So why would doctors misinform you about bone spurs? Well, the most common reason is they want to treat you. They want your money or your insurance company's money. So they will tell you the bone spurs need to come out. And what happens every single time? You'll get an MRI or X-ray after surgery and you'll see the bone spurs are still there. Why? Because they never planned to get the bone spurs out. They just use the bone spurs to get you to do their surgery. I never tell patients we're doing surgery for bone spurs. I tell patients we're doing surgery because your disc is causing symptoms. And those symptoms can only be fixed with surgery on the disc. And that is the absolute truth in this day and age. Unless you have the hand of God, you cannot magically wave something and make the discs stop hurting. So the only way to make discs stop hurting is this surgery you're watching right now, Duke laser disc repair. The other way you can do it is by removing the disc and fusing. Which, who wants a fusion if you don't need it? I wouldn't. It's the last thing in the world I would do. And it has nothing to do with the fusion, by the way. It has to do with the crazy surgeons that are recommending them. Fusions are basically highly invasive and dangerous. Why are they dangerous, Dr. Berndes?
Because you have risk of anesthesia, you have risk of blood loss, you have risk of infection.
Yeah. Complications, that's why. And I'll tell you something, if you don't think complications are serious, they are.
Risk of transfusion reaction.
Oh, yeah. I can tell you right now, I have seen, not in my patients, but in other doctors' patients, countless complications from fusions, countless. As a matter of fact, our next patient is one of them. Our next patient has a cervical fusion done in Texas. He's from Texas. And he's here because, well, after his fusion, he still had pain. It got worse. Didn't get better. Lo and behold, he has a fusion at C4-5. We're going to be going and trying to fix 5-6-6-7. Adjacent segment disease. On top of that, he's got facet pain at 3-4, above his fusion. So the fusion caused worsening of the discs and facets above and below his fusion, which is why we don't like to do fusions. They cause complications. That's the biggest reason. Now, if a fusion is done without complications, they can help patients with disc problems. Stenosis, sorry, Louise. Okay? But the problem is finding a surgeon that can do a fusion without complications. I know one. Just one. That's me. But besides me, I don't know of any. And I stopped doing fusions because they're too invasive compared to laser. Who wants a fusion? Nobody. Nobody. All right, any questions?
No current questions.
Is it 8.5 or?
8.5.
All right. Here.
Well, the other one.
Sorry. Yeah. All right. Well, let's show our audience how does this Duke laser disc repair thing even work? What are we doing in here anyway? That is a bone spur right there. Goodbye, bone spur.
Disc herniations are a common cause of chronic neck pain.
All right, we are just about done. Literally a minute left here at 6-7. And I've done pretty much what I can. Most of the disc was collapsed, degenerated, but there was definitely some stenosis here that you could see. And we're using the laser to get the pressure off those nerves in the neural foramen right there. I removed a lot of that scar tissue and disc material,
Lights on, please. Thank you.
and I'm happy with that. That's as good as we can do safely. And the good news is I've never had a patient where I wasn't able to get rid of their arm symptoms no matter how collapsed their disc was. As long as the arm symptoms are coming from the area that I'm operating on. So if I'm fixing 6-7, but they have a herniation somewhere else, or they have some other problem like tennis elbow, oh no, we need to do more irrigation. Yeah. There's still betadine. That looks good. Any questions from the audience?
No current questions.
All right, Luis, good job. Whoops. All right, come on in, Jordan. Big J. Jordan is our X-ray technologist, laser technician extraordinaire, fellow anatomist. Great job, everyone. Look at that. Beautiful. All right, I would say let's go north a smidgen. And there we go. All right, there's 2. I think that's too much north. 2, 3, 4, 5, 6, 7. I would just the tiniest bit south. We've literally lost 1 drop of blood the whole surgery so far, and it's been going really well. I'm going to take this tube out, leaving the dilator in. Nice job, Jordan. That's perfect. Everyone be ready because we're about to move to our next location. All righty then. Any questions? Shot?
No current questions.
Now we call this move the Duke slide. I got my inspiration from the electric slide. Anybody know the electric slide, the Macarena? Huh? Right? I like that. All right, I'm out. I just popped out, shot. I'm on the spine. I think I'm a little to his right, but let's get an AP and see where we are. Relax. So I need to check my AP, my front back. AP is front back. Shot. I want to make sure I'm in the middle. We are too much to his left. I need to come back to the right. Shot. Want to come back a little bit more. I think I'm going back in the hole. Shot. Shot. Let's see. Shot. That felt pretty good. Let's go with the lateral, see where we are. I think there's some twisting of his spine. We've just got to be careful with that. All right, that looks pretty good. I want to move up. Shot. Just about there. Oh yeah, there we go. Shot. All right, definitely there, but are we in the middle? Shot. I feel the disc. Let's get an AP. I felt like I moved off to his right. So did I go too far to the right? Or are we good? Shot. Oh, it's perfect. All right, let's go back to a lateral. So at this point, we are in the center of the spine and we're in the center of the disc on the lateral view. So we're in good position. I'm going to advance this shot dilator into the disc. Shot. And 2, 3, 4, 5, 6. Man, I could really feel you moving them. Hold on. And shot. All right, you can relax. Now I got to clean out the dilator's channel because it's got maybe some disc schmutz in there. Shot. That's our technical term, medical term, disc schmutz. You like that, Sanjay? Shot?
Yes, I do.
Highly technical. All right. I don't know if I got it out or not. Shot? Is that it? Right there? Oh, man. I don't think I got it out. No. No. I got too much schmutz in there. Shot? Yeah. We're not going to be able to do a discogram. Oh, well. Let me advance this all the way back. 2, 3, 4, 5, 6. Everyone agrees. 5, 6. Shot? Uh-huh. Perfect. Tube. All right, at this point, we're going to bring our tube down. Let's get an AP. Just want to make sure. His spine is so off. Damn, it looks good. That looks about as good as it can look. Just looks weird on the surface because of his scoliosis. We are not fixing scoliosis, by the way. Some people might say, well, how can you just ignore the scoliosis? Because the scoliosis isn't causing any symptoms. That's why. And I don't believe in trying to treat things that don't cause symptoms for patients. You shouldn't. Besides, the only way to treat the scoliosis is fusion. Watch that dilator. You watch the dilator, Luis. That's all you do. Shot. I feel myself moving at millimeters, which is fine. All right, Luis, let me take this, and you take care of that, and watch the dilator. I don't want it going any further. We may have to pull it back a little bit. It's right at the tip of where I want it. I need a little more distraction. All right. That's probably maybe as good as I'm going to get this. Let's bring the dilator back a little bit. You gave me as good as you can, right? The disc is, again, just cement with scar tissue. All right, a little distraction so we can get this out. Okay, relax, relax, relax. It shouldn't have any resistance at this point. You're just bending it. You understand what I'm saying? Let go, let go, let go. Take that off. As you're coming out, if you pull this way, you're going to bend it here against the tube, and it's going to feel like there's resistance. But as soon as you're out of that back part, you should be fine. All right, that's as far back as I can go. We've got 10 minutes, Dr. Berndes, if you want to start waking the patient up. Any questions from our audience? You're watching a cervical Duke laser disc repair in a patient with cervical radiculitis, neck pain, and herniated discs that over time have become degenerated discs. That's what happens with an untreated herniation. If you don't treat your herniations, they destroy your disc. So, best thing to do, get them fixed, especially if they're symptomatic. If they're hurting you, it's telling you there's a problem. And you got to listen to your body. Get it fixed. Grab her. No questions.
No current questions, no.
Do we have this surgery on the calendar?
I believe so, yeah.
I mean, what's our attendance if we have no questions?
Right now we have about 12 people on our 3 main social media accounts. It doesn't say for LinkedIn or Twitter, but I assume a couple of people are watching from that platforms as well.
That's pretty horrible. I mean, how do we get more views from these platforms? Are we not tagging these video streams?
I make sure to tag them, yeah.
Well, I mean, tag them, but are you tagging them in a way that people interested in spine surgery would actually find them? You know what I mean?
Of
Is
course.
there something we can do better?
Sanjay and I will figure it out.
Because to me, you guys got to get on Reddit. I mean, we can't just keep, it's okay to record and stream. It's wonderful. But there's a lot of people out there with spine problems and they're not finding us. So I'm just trying to figure out why. And I think it has to do with our tagging, but I could be wrong. I would hop on Reddit and try to figure it out.
Copy that.
I don't want to pay to boost these things. I'm not going to. Just feel like there's a large audience we're not getting to. All right, so, oh yeah. This disc is pretty degenerated as well. Come on. To me, this disc is worse in ways than the last one. It's more collapsed. 5 minutes. But there's not much disc left. You can see it's all just this white stuff, which is really scarred up, degenerated material. I don't really see any herniation back here. Very little, if any. There's a little bit here. Yeah, thank you. Mostly calcified annulus inflammatory tissue, just burn out. These little islands of dried up nucleus and end plate cartilage that was coating the surface of these bones, long gone, destroyed a long time ago. What is that noise? Is that the nerve tester?
Yeah, I was just making sure.
Yeah, we got about 2 minutes left. All right, if you have questions, this is the time to ask them. We're almost done with the surgery. Again, this is a patient who's traveled from overseas to Florida to the Duke Spine Institute to have this particular surgery and the Deke PR done. We've already completed the Duke plasma rhizotomy earlier. And this is our second phase, phase 2 for today. And then I think he's coming back Thursday, right, to have, what do you call it, the lumbar, the lower back done. Now, you can see the posterior ligament there. Not much herniation left, there's just this dried up stuff that's just floating out, getting rid of it. So this disc was more degenerated, but less residual herniation to remove. You can see the fibers of the PLL. It's kind of cool. You can see the back of the disc right there. Look at the fibers of the PLL right. That's the spinal cord down there. All right, so I didn't know it was that funny. Is it? Luis? Luis is making you laugh? He's a comedian now? Oh my gosh, Luis is a comedian now. I didn't know that. All right, yeah, we're done. We're done. That's it right there. That was the last piece. Great job, everyone. Thank you. Well, if you wanted to ask a question, you're welcome to, but we've only got another minute or two. Ask it now or forever hold your peace. Huh? You may have to straighten that out a bit. Looking good. All right, we're gonna suck the fluids out of here and then we're gonna be done. Oh. I'm going to show you this incision, folks. Take a look at this thing. It's 4 millimeters. Our patient, once again, is from Australia, Melbourne. Came to Melbourne, Florida to have his neck fixed. A lot of pain, kept him from doing everything he wants to do. You go ahead and break down. And we fixed his neck today with 2 procedures, one through the front called the Duke laser disc repair, fixing a herniated degenerative disc. And then the other one was through the back called the Duke plasma rhizotomy, basically fixing facet joint pain. There's the incision. You guys see that?
Yes, we do.
It's about 6 millimeters today. No bleeding. I think he lost maybe 3 drops of blood, 4 drops of blood. That's about it. So it's bloodless surgery, outpatient, no hospitalization needed. The patient doesn't need fusion. We're able to fix the neck with the spine without fusion. Great job, team. Thanks for watching. If there's no questions, you can end the live stream.